Hola, hola, vamos a dar inicio a la sesión de... Hola, ahora sí. Vamos a dar inicio a la sesión de casos clínicos del Club de Nefropatología. Lo vamos a moderar la doctora Ana Huerta y yo, Francisco Díaz, y vamos a dar introducción al ponente invitado a esta sesión. Ana,
Muchas gracias. Le vamos a presentar en inglés. We have the pleasure of having Professor Anders here. He is the head of Renal Division of Inner City Campus of the University of Munich. He's an expert in different areas of clinical nephrology. He works on the molecular mechanism of kidney injury and repair. He also works in kidney remodeling in chronic kidney disease. He is also an expert in primary and secondary glomerular disease. He has participated in the lupus nephritis guides of the European Nephrology and Rheumatology Group. And today he is going to talk about refractory lupus nephritis. Thank you so much.
Ladies and gentlemen, thank you for the kind invitation and the introduction. The microphone works? Okay. So refractory lupus nephritis was the topic I was given today. And for those of you that came here to hear about the latest treatments, I'll have to disappoint you. I won't speak about stem cell transplantation. I won't speak about CAR T cells or immune absorption or any of the other fancy things that are done in this context. I will try to convince you that there is no refractory lupus nephritis. So there is a lot of literature about refractory lupus nephritis, and we all have encountered patients that didn't respond to standard of care therapy and or that come back with a disease even though properly treated. And I will try to touch a bit on the different reasons for this. So I will speak about the one-size-fits-all approach, as it's, for example, published in the KDIGO guidelines. What is refractory lupus nephritis and does it at all exist, and how we may be able to do better. So this is the one-size-fits-all approach. This is what you find in the guidelines. And indeed, the KDIGO guidelines provide 5 different ways how to do induction therapy of lupus nephritis, but this is not personalized medicine. This is just illustrating how it's done all over the world. So for example, tacrolimus low-dose MMF is the standard regime in China, and in some parts of the world, they still keep using oral cyclophosphamide, maybe for cost reasons or other reasons. In Germany, we use either low-dose cyclophosphamide or MMF, and we have no data that supports one or the other, so it's a choice of the patient after careful counseling. But also, this is not really a good personalized medicine. The guidelines say if you don't respond to any of those, switch to the other, which is also a bit strange to imagine. If it's an autoimmune disease, it should respond to standard of care, right? It's hard to believe that an autoimmune disease doesn't respond to steroids or immunosuppressants. So if it doesn't respond, maybe there's something else. So this is the usual concept behind what's written in the guidelines. For some miraculous reason, the lupus nephritis of this patient doesn't respond to standard of care, but lupus is still poorly understood, and the lupus of this patient must be particularly bad, so let's increase a bit the immunosuppressive therapy. And then what happens if you give more steroids and longer, you increase MMF to 3 grams, you switch to high-dose cyclophosphamide NIH regimen or extend beyond 6 pulses, you start to combine with any of the new drugs, voclosporin, belimumab maybe, or some people even use immune absorption, plasmapheresis, or IVIG. And some people even publish on stem cell transplantation has a 10% mortality, something I would be very careful about. We wrote an editorial on the Chinese studies that seemed to use stem cell treatment for almost everyone, couldn't really understand what was refractory there. So this is something we never do in our hospital. So what is refractory lupus nephritis? We had to suspect that there's no clear understanding of what it really is, and we made a survey at the ERA, you may remember me standing at the doors of a room like this, handing out questionnaires to many people. So we got several hundred returns from lupus experts and from also different world regions. And we asked simple questions. So what is the right time point to evaluate refractory lupus nephritis? And here you can see what was the result, more or less the same across the different kinds of treatments chosen. No one knows. Some people ask this question at 3 months, some ask this question at 6 months, some ask this question after 1 year. So when is the time to conclude that this lupus is refractory? There's no consensus and everyone has its own ideas about it. Then on which parameters should you base this conclusion, refractory lupus nephritis? And here we listed a couple. Everyone chooses what wants. So there's no consensus, there's no clear definition of refractory lupus nephritis. Everyone uses this term, but everyone goes home with his own ideas about what that means, and this is not the right way how to define clear treatment algorithms. Even the proteinuria threshold, we asked the people, what is your proteinuria threshold to define refractory lupus nephritis? And you could find here almost everything across a broad range. So that means everyone has its own ideas, and this is not how we can bring on a field. When asking what you consider a potential cause for refractory lupus nephritis, almost everyone assumes that there's a persistent immunological activity. But no one really checks for that, for example, by rebiopsy. So how can you define a persistent immunological activity without a kidney biopsy? I don't know. Some assume proteinuria as an indicator of this, but we know as nephrologists proteinuria has a big differential diagnosis. So there's also no consensus on this, actually. When you talk to lupus experts that see a lot of lupus nephritis, they all tell you most of refractory lupus nephritis is drug non-adherence. And I see some people nodding. I think this really depends on the way how you can take care of your patients. I'm in a lucky position. I have my patients in 30-minute slots, so I have time, a lot of time to talk to them. But I know in some places, patients are seen in 10-minute slots, or you have seen such pictures in China, right, where 200 people are waiting in front of a single office to be seen. So there are some people doing 5-minute slots for patients. There's no way that my patient would adhere to a drug where I speak only 5 minutes to tell them how to use them, all the side effects, and so on. So I think my patients are adherent because I explain them a lot about the disease and they become lupus experts. They have to become lupus experts. Otherwise, there's no way that a young female takes 10 pills a day. You know, I could make you the list of all the pills a lupus nephritis patient has to take. These are young females. They take maybe the 10 pills a day the first weeks. Once the edema disappear, they are quite reluctant to go on taking 10 pills a day. And now with voclosporin, they want you to take 16 pills a day because voclosporin is 6 pills a day. So that means we know it from hypertension. Your adherence goes down from the first to the second pill to take, and in lupus is not any different. So you have to speak a lot. You have to educate the patients by making them experts, read about lupus nephritis. I use smartphone apps that ring 3 times a day to remind them to take the pills. Young people are quite open for these kind of things. You can measure drug levels. You can question refill intervals. There are many ways to address drug adherence, and this never appears in any of these lupus talks, but I think it's a much better way to improve lupus nephritis outcomes than inventing another new immunosuppressive drug. Just simply have to work on that the patients really take the drugs. And imagine in certain parts of the world, there seems to be more refractory lupus nephritis than in others, and this may have a lot to do with education of patients and how the care is done. The other thing we do when a patient comes back or doesn't really respond to treatment, we question the diagnosis. Of course, there was a biopsy done 3 months ago or 6 months ago, but if a patient doesn't respond, there's something wrong. You know that from, for example, steroid-resistant nephrotic syndrome. So I have a patient with nephrotic syndrome, biopsy done or not, in a kid maybe not, you give steroids, and when the patient doesn't respond, you know that 70% of these patients have a genetic cause, you know. So that means the initial treatment is a diagnostic test. If the disease responds to steroids, it's autoimmune. If it doesn't respond, maybe it's something else. So we do rebiopsies in patients that don't respond, and we found a couple of interesting things. The first 2 are genetic diagnosis. So in this second round of diagnostic, we also do genetics, like in steroid-resistant nephrotic syndrome, and I will show you the case later on. But with a rebiopsy, we found other things like C3GN or C3-TMA. And we even found an incident ANCA vasculitis in a patient that was treated with induction therapy for lupus nephritis. All of a sudden had ANCA and vasculitic lesions in the biopsy. So, I mean, these things occur. Maybe they are not so common, but altogether they are more common than what we think. And probably after drug non-adherence, it's the most common form of refractory lupus nephritis. And you will never discover that if you simply switch from one regimen to the other. So you need to have a second round of diagnostics, including a rebiopsy, maybe genetics, to identify these cases. This is another thing that the rheumatologists, for example, don't know. This is a lupus podocytopathy due to chloroquine. This needs electron microscopy to figure out. So there have been many case reports, and even at the S.E.N. last week, there was another report, patient treated for scleroderma with chloroquine, all of a sudden developed nephrotic syndrome, and then they found this. So there are quite some reports about this, and probably this is missed quite frequently. Chloroquine patients do not only get pigment deposits in the retina, but also in the kidney. And if it ends up in podocytes, it can lead to persistent proteinuria or even nephrotic syndrome. And this here immunosuppression doesn't help. You need to stop the chloroquine. And then it can even undergo remission. But this needs a rebiopsy. So the KDIGO guidelines are a bit ahead of the last EULA ERA guidelines of lupus nephritis, and they address this with that schematic. Here they say verify adherence to treatment as a first thing. It's no surprise, this was all written by Brad Rovin, right? And he's one of the people that sees many lupus nephritis patients himself. Then check the adequate dosing and look out for other diagnosis, which implies a rebiopsy. So this is something. And as nephrologists, we know even better than rheumatologists the differential diagnosis of proteinuria. If you have a patient with 120 kilos and the proteinuria doesn't come down, you know, is that really refractory lupus nephritis? Maybe it's simply obesity. So, I mean, or the salty diet. I mean, I tell my patients, stop the frozen pizza, stop the crackers and the salty popcorn. And then some people even don't know what to eat anymore. So, I mean, the young people have funny diets and they are pretty salty rich, and this, as we know, can be cause resistance to ACE inhibitors and other drugs and be a reason for persistent proteinuria. So, how to do better? Okay, we have to replace this standard approach by personalized medicine. Our patients are different one from the other. We call them all lupus, but we know that lupus is a syndrome of many different diseases. There are so many different forms of monogenetic lupus that none has nothing to do with the other, but they all share antinuclear antibodies and eventually kidney inflammation. So that means they all look the same, but they may have the disease for different reasons, and also progression may occur for different reasons. That's why it needs to spend some time with the patient, a second round of diagnostics, and to see if any of these alternative reasons may be there. Drug non-adherence applies to some of them. Rebiopsy is needed to find out whether the proteinuria that persists is really due to a lack of immunological remission, and that gives you the suspicion of drug non-adherence, or sometimes the proteinuria is gone. It is still there, but the immune complexes have disappeared, so it means this has another explanation. Genetic testing and immunoprofiling, so I will go through these things. So first, the rebiopsy issue. You may not know that there's currently an ongoing study to which you could participate if you want. That is the ReBiolup study. It's done by Fred Housseau from Brussels. This is the rheumatologist that did all the Eurolupus trials. The fundament of what we're all doing now with our patients. So he is close to retirement, but he said, this is the last trial I will do in my career. And he joined with Johannes Parodis from Stockholm and some other people. I'm also in that board. But I mean, this is a really an interesting trial. It's an investigator-initiated trial, no funding, and it invites everyone that wants to participate to participate. It will randomize patients to a rebiopsy done after 1 year. So that's what I do in my institution now. If I do the first biopsy, I tell the patient, you will need another one in 1 year from now to check whether the treatment worked or not, because From the urine and the blood test, we cannot know. So we tell the patients, you can do a biopsy, but obviously some don't want, I mean, here we will randomize the patients to those that get a rebiopsy and those that don't get them. And then the question is, 5 years later, does the rebiopsy has an impact on outcome? And the assumption is that you will acquire some information in the rebiopsy that will make you change the treatment in some way that outcome will be better. And this trial design doesn't tell you what to do with the results of the biopsy. It's up to your own choice. It's just based on the assumption that doing the biopsy will provide important information. In transplantation, we do biopsies all the time, even protocol biopsies. And the question is why we don't do that also in lupus nephritis, at least a second one, to check whether the induction treatment worked or not. And we assume that this will provide information that will help us to better individualize the treatment. This is just one case published 10 years ago in the Annals of Rheumatic Diseases. A patient with persistent nephrotic syndrome obviously didn't respond to immunosuppressive treatment, so you could call it refractory lupus nephritis. And this was the first biopsy where they had all these immune complexes. Here it was a class 5, so epimembranous deposits of immune complexes. And this was the second biopsy. And what you can see here, that all the immune complexes have disappeared, but the podocytes are still in bad shape. Okay? We know now from the phospholipase A2 experience that proteinuria resolves with some delay after resolution of the immunological problem. So we know it takes more time. So in lupus, it can be the same, that you have perfectly treated the autoimmune disorder, but the proteinuria is still there because podocytes still in bad shape. Here, switching from MMF to cyclophosphamide or the other way around won't help this problem. So here you need to increase the ACE inhibitors, maybe SGLT2 inhibitor, whatever you can do to reduce the hemodynamic stress of these podocytes. And this is something that you cannot know without a rebiopsy. And that's why we need to do rebiopsies up to this moment where we will have better biomarkers that can replace the rebiopsy. But these biomarkers will have to be validated against that rebiopsy. We have so many biomarker studies in lupus nephritis, but all refer them to the initial biopsy. But that's exactly the moment where I don't need a biomarker. I do the biopsy anyway for diagnostic reasons, right? How a biomarker can replace this first biopsy? It won't. So we need biomarkers to replace the second biopsy, but to establish these biomarkers, we first need to do these rebiopsies, otherwise we cannot validate them. So that's why, at least transiently, we will need that rebiopsy. And hopefully will improve outcome, that's the assumption. The question is then also how to define immunological remission, because complement factors keep to stay there for a lot of time. And this I find interesting in view of all these IgA studies that are currently done, where you can enter with a biopsy 10 years old and have proteinuria of 1 gram, and then they give you a complement inhibitor with the assumption that the proteinuria has anything to do with that, with complement. So maybe many of our IgA patients have complement that is there since 10 years. You know, from the IgA vasculitis they had 10 years ago. Who knows? Certain complement factors stay there for a lot of time, and we still don't know exactly if it really represents active lupus nephritis. But we have activity index since 20 years in lupus nephritis. I don't know, it's not used in IgA or any other immune complex glomerulonephritis, but at least in lupus nephritis we have it. And rebiopsy studies show if your activity index is bigger than 1, you benefit from further immunosuppressive therapy. So that means immunological resolution may be judged also by injury, and this can be assessed in a rebiopsy. I'm not interested in a rebiopsy, which class 3, 4, 5. I also think these classes we should bypass after a while. We do this since 50 years, I don't know why. We treat them all the same, class 3, 4, 5. But so the rebiopsy is not done to figure out the classes. The class switch doesn't have a consequence for treatment. The only thing I do the biopsy is I want to know activity index and to rule out alternative diagnosis. Activity index tells me how much immunosuppression I need, and chronicity index, all the things I missed in the first year. So this rebiopsy can help us to detect podocytopathies, so it means podocyte injury without immune complexes, and this would prime genetic testing for podocytopathies. Then we could find a C3GN or a TMA, and maybe in the near future we will use complement inhibitors for these patients and eventually also genetic testing. A pure TMA associated with phospholipid antibodies would require a completely different treatment. and only those that have persistent full house pattern together with activity would benefit maybe from enhancing immunosuppressive or to restart immunosuppressive therapy in non-adherence or to switch. Then genetic testing is another way of the second diagnostic round, should include APOL1. So I don't know the situation in Spain. I can only say that in our dialysis unit, 1/3 of the patients are from Africa. We also have them in Europe. So, and many of them are APOL1 patients, so this is something we consider. And I want just to show you a case of a patient that had, from West Africa, was a girl at age 14, came to pediatric nephrology, had class 2 plus nephrotic syndrome. This is a proteinuria level. Class 2 with nephrotic syndrome, this is something that nowadays we would call lupus podocytopathy, means a nephrotic syndrome that is not explained by the lupus. So you need to do genetic testing to figure out what's wrong, because it's obviously something else. But at that time, she received standard immunosuppressive therapy, and she went into remission that lasted for a couple of years when she was taking the pills. Then, you know, she was 17 something, stopped taking the pills, and then had a relapse. And with that relapse, in the meantime, they even did a rebiopsy, which was quite innovative at that time. We were not discussing that, but they did a rebiopsy and found a 1 FSGS lesion, which they thought was post-lupus. But looking back, obviously it was not. But when she had the relapse, another biopsy done, lupus nephritis class 5. So again, immunosuppressive therapy, but this time she didn't go in remission anymore. So refractory lupus nephritis, and 2 years later she was on dialysis. So, and meanwhile she turned 18. I encountered her here. We did one last biopsy. It was class 6, so everything lost, and she ended on dialysis. So I said, listen, I've never seen a lupus like this. This doesn't exist. It cannot be lupus. So we went for genetic testing, also of the parents, and they were from the same village in Senegal. And what turned out is that she was the unlucky one that had inherited from both parents a nephrin mutation. So she was a homozygous nephrin mutant, had a primary genetic FSGS, so to say, adult onset. Could have been even more unlucky to have nephrotic syndrome of the Finnish type, could have been born with that, but she wasn't, was a minor mutation. And she also had inherited from both parents APOL1 risk alleles, so she had 3 kidney problems. One was the lupus, that was not even her biggest problem, but then she had a primary FSGS plus APOL1 risk alleles. That's why she jumped to dialysis within a few years. And you see what happened here, all the immunosuppressive drugs listed that were given according to guidelines, you know, always increasing immunosuppressive drugs, but her proteinuria was not because of the lupus. And no one can say we didn't do biopsies. We did 5 biopsies in this poor lady. But nowadays, if I encounter a patient with a class 2 with nephrotic syndrome, I would do the genetic from the beginning, because this is not a nephrotic syndrome that can be explained by lupus, and probably we would have saved her from at least a couple of these immunosuppressive drugs, knowing what was her problem. Meanwhile, we would not do genetics only for these 30 or 40 podocyte genes, because colleagues from Florence have figured out that you can double the diagnostic rate in nephrotic syndrome, in steroid-resistant nephrotic syndrome, if you look for all nephropathic genes. Now they are 400 or 500. This you can do only with whole exome sequencing now, and there are, they call them the phenocopies. These are mutation and genes that are not described to do nephrotic syndrome, but sometimes they anyway do it. So that means if you start from nephrotic syndrome, you find also these genes, and this is a diagnostic rate of more than 60% in patients with nephrotic syndrome that doesn't respond adequately to immunosuppression. And this is not only minimal change disease, this is also patients that come with lupus nephritis. If they don't respond properly and they have, let's say, a class 2 with a nephrotic syndrome, is highly suspicious of something else, a podocyte weakness, where 3 immune complexes induce a nephrotic syndrome. Must be an additional podocyte weakness. So immunoprofiling can be done nowadays in many ways, and some authors have used transcriptomic analysis or other omics methods. Was published in Cell, a lupus paper in Cell, fantastic at that time. Meanwhile, we had other publications in Nature Immunology doing single-cell RNA-seq on kidney biopsies and so on. I'm not entirely sure if this will help us to individualize treatment, but it's certainly currently done, and this study was particularly attractive because it had long-term follow-ups and could correlate certain transcriptome patterns with outcomes. So maybe in the future this can be something. What some of my colleagues at the Charité in Berlin do, they do flow cytometry of the urine for T cells. And in this manner, they are able to detect activity of lupus nephritis, what otherwise you cannot judge. So proteinuric patients, relapse of immunological activity, yes or no, they do the FACS of the urine, then they tell you. So this is established in certain centers. Extended immunophenotyping is not yet standard, obviously. But from all this, I would conclude something else. Maybe in lupus, you know, we have these 20, 30 trials that all failed because the primary endpoint didn't reach the p-value, and then the drug was no longer continued, the program for patients with lupus nephritis. But in all these trials, there were patients that responded to that treatment. So for them, it was the perfect drug. So if you assume that lupus is not a single disease, but this is a collection of patients with many different diseases, there are some that respond to drugs that are not approved because the trial didn't make it. The p-value was not significant, means it didn't help the majority of the patient, but it obviously helped some patients. So if you would only go back to those trials and look what were the characteristics of those patients that responded to some of the treatments, we would have all of a sudden 10 or 20 more drugs for lupus nephritis and could individualize the treatments better. So these are lost opportunities for the moment. And currently that some trials have become positive now, I think no one is really willing to go back to these old data. But this is the main concept, that patients are not all the same. There is not the one-fits-all approach, and with a better immunophenotyping, we could be able to stratify patients a bit better. So I'm coming to an end. If it's lupus nephritis, it should respond to immunosuppressive therapy. If it doesn't, you have to be suspicious for something else and ask yourself, we need a consensus definition of refractory lupus nephritis, and currently in the Lupus Nephritis Trials Network, we are working on that. The first thing to rule out is drug non-adherence, and you can ask the patient, did you take the pills, because this would be the easiest way to solve your problem, or I will have to switch to chemotherapy. This is the way I speak about cyclophosphamide. And then some patients admit, you know, that the pills sometimes no, and actually in the last 3 months, not at all. And then you have an easy answer to the persistent proteinuria. Yeah. Anyway, we need a second round of diagnostics, which includes rebiopsy and eventually genetic testing, obesity, diabetes, all these other reasons for hyperfiltration, high salt diet may explain persistent proteinuria and need a different approach. Protocol biopsy requires a good definition of immunological remission. Genetic testing for upper one podocytopathies, phenocopys, and complementopathies is now available in most academic centers. And secondary autoimmune complementopathies are interesting. Lupus patients develop anti-factor H antibodies. They develop anti-factor B antibodies. So some patients develop secondary complement disorders as part of the systemic autoimmunity. Immunoprofiling is needed for personalized treatment. Okay, so this is my final slide. This is the way how I see the treatment of lupus nephritis for now. In most sessions on lupus nephritis, we talk all the time about this. The DMARDs, how the rheumatologists call them, the disease-modifying anti-rheumatic drugs, and there's a lot of industry activity in this domain, but it's not that we don't have drugs here. Huh? We have actually a lot, and if the patients take them, maybe there's not so much unmet medical need. We have to work more on the adherence problem, and we may also need some studies on this. We have now a new class. I call them the cardio-renoprotective drugs, you know, the ACE inhibitors, the SGLT2 inhibitors. Yeah? If you speak to rheumatologists about SGLT2 inhibitors, they ask you SGL what? So they have not yet heard about it. So I think it's our role to educate them that they give the RAS inhibitor not only to treat hypertension in lupus. Huh? So if you want to improve outcomes, we also need to reduce cardiovascular morbidity, mortality. I mean, young lupus patients become at some point old lupus patients, you know, so acquire other risk factors. So this is up here, and the big questions are, what did the 60 lupus nephritis patients do in the EMPA kidney trial? You know, I would like to know, because there we had the first lupus patients in there. And of course, the COVID pandemic told us vaccine, 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 and less steroids is a way to prevent infections. Infections is the first cause of death in patients with lupus nephritis, so we should remind that. And there are ways to tackle that, so it means we speak a lot about vaccination in my lupus clinic now. Thank you.
Thank you so much for this wonderful talk. Se abre el turno de preguntas.
Thanks. For the therapy, because I have the feeling that for class 5, that you have membranous nephropathy associated to lupus, maybe that one is not the same that if you have 3 or 4. So can you explain a little bit more on that?
Also, membranous is an autoimmune GN, has a similar antigens. 1/3 of the patient has this exostosin in the glomerulus. We don't know why and what it does there, but for the moment it doesn't affect treatment. There are some suggestions to prioritize MMF in patients with membranous lupus nephritis. The new trials have shown not such a strong efficacy for class 5, which may also relate that these patients are always underrepresented in the trials. I think from a therapeutic point of view, we don't really know exactly what to do with that, but I'm not completely neglecting the class in the first diagnostic biopsy. But when I do the second biopsy, I don't care if there is a switch from one to the other because it doesn't change my treatment. I only want to know, is there immunological activity, and this is provided by the activity index. So that means I write on my pathology request, I write not the lupus nephritis question mark, I write the activity index question mark, chronicity index question mark, because these are the only things I consider for management in the second biopsy.
Thank you.
Thank you, Achi. Okay. Thank you for your talk. Excellent as always. You say that everyone knows that time to achieve proteinuria decrease is very important. It's very important for the future of the kidney. But we say that membranous nephropathy learned to us that in immunology disease, the time to the podocyte recover is a couple of months at least. So, in your opinion, how much or how long we have to expect or we have to wait to change our therapeutical approach? Because in my opinion, sometimes we change very soon and we get rid of drugs that if you wait, they are going to run. Maybe you have to expect, but maybe sometimes you don't know when you have to stop and we have to wait.
This is a very important question, and this also highlights how much we are in need of humoral markers of the immune response. I mean, Brett Roven has suggested now in this question, voclosporin or belimumab, that we look after 3 months, and if you have a 25% reduction, you can be confident and may simply wait. If you don't have this 25% of reduction, then maybe you should think to add something else like belimumab or voclosporin. This is not how the trials were done. This is not what the evidence tells us for the moment. This is a pragmatic way, especially if you don't have the money to start all these costly drugs from the very first day, right? So, but I think these proteinuria levels are also a bit of a problem, because if now people start working with voclosporin, this is a drug that brings you down proteinuria after 2 weeks to a level that has nothing to do with the immune system, so this is only because of podocyte stabilization. If now we use SGLT2 inhibitors, some may wait for a month, some may start from the very first day to reduce the pressure in an injured glomerulus, to reduce damage. This will affect your proteinuria level. If the patient listens to your advice to avoid salty food, you will have a 25% reduction of proteinuria only for that reason. So it's very difficult to give standard levels of proteinuria, and you know even the UPCR is a very variable thing. If you do that on 3 days, one after the other, you get 3 different numbers. So it's very difficult to give these kind of thresholds. I think what is important to really look at the patient, if the patient feels better, if everything goes in the right direction, if the skin and whatever shows the same, then I can be confident and I can simply wait a bit more to the proteinuria to come down. If the patient tells me I cannot sleep anymore, I have this tremor and whatever, this steroids makes me crazy, you can already have some suspect that maybe there's a problem with adherence and things like this. Maybe switching to an IV regimen, maybe belimumab, an injection every week is something to help adherence, or at least to make sure that something is taken, you know. I think one has to simply look the patient carefully and see if it goes in the right direction. And if it doesn't, adherence, rebiopsy, and other diagnostic to think about. We don't automatically switch from MMF to cyclophosphamide or the other way around. With this, we do after careful assessment.
Thank you so much. We don't have more time for any questions, so thank you so much for your presentation. Ahora, por favor, invitamos a los ponentes de los casos, si se pueden sentar aquí. Empezamos con el primer caso. Preséntalo tú, si quieres. Yo me pongo al lado de ella.
El primer caso se titula Nefropatía secundaria a intoxicación por mercurio. ¿Y ahora qué hacemos? Presenta Coraima Claudia Nava Chávez y Francisco Díaz.
Pues muy bien, hola, buen día. Voy a presentar el caso clínico de nefropatía secundaria e intoxicación por mercurio. Se trata de un varón de 56 años cuyos antecedentes personales más relevantes son una infección VIH con un control inmunovirológico, una hepatitis crónica por un virus C, genotipo 1A tratada, y una enfermedad renal crónica puesta en el contexto del tratamiento antiviral con una creatinina basal alrededor de 1,2, un trastorno de la personalidad mixto con episodios de depresión recurrentes, una historia de dependencia a múltiples tóxicos y, a consecuencia de un accidente de tránsito en el 2017, un deterioro neurocognitivo y una hemiparesia derecha como secuelas. En septiembre del 2021 ingresa para un estudio por un hallazgo de múltiples lesiones milimétricas en una radiografía de tórax que fue solicitada por una prueba positiva de Mantux. En el informe, el material parecía tratarse de mercurio. Reinterrogado, confiesa la autoinstilación intramuscular de mercurio procedente de termómetros en 2 ocasiones en los 2 últimos años. Tenía niveles plasmáticos de mercurio y urinarios elevados, un deterioro de la función renal hasta 2,38 miligramos de cilitro de creatinina, una proteinuria en rango nefrótico, sin alcanzar el síndrome nefrótico, y pruebas inmunológicas, incluidas plados-R negativas, serologías negativas, a excepción de la virus C, ya conocida, y crioglobulinas negativas. Pues no sé. Esta es la radiografía de tórax que motivó el estudio. Esa es la radiografía de abdomen y el escáner que mostraba el depósito tanto a nivel visceral como en los ganglios del depósito de hierro o de mercurio, por ejemplo. Se intentó mediante escopia la retirada del mercurio sin éxito. Por tanto, ante la proteinuria en rango nefrótico, el deterioro de la función del riñón, se decidió la realización de una biopsia renal.
Bueno, en este caso tenemos un cilindro de parénquima renal constituido en aproximadamente un 80% por cortical, en el que se observa ya a pequeño aumento una alteración de la arquitectura, específicamente ya se ve alteración a nivel del intersticio. Si nos centramos en el compartimiento glomerular, habían aproximadamente 30 glomérulos, de los cuales entre un 15 y un 20% estaban esclerosados, y los viables mostraban algunos cambios glomeruloquísticos, pero llamaba la atención una marcada un marcado engrosamiento de las asas capilares y algo de proliferación endocapilar. Con las diferentes técnicas de histoquímica vemos que las asas capilares se ve perfectamente la proliferación endocapilar, el engrosamiento de las asas capilares y en la técnica de plata la presencia de proyecciones espiculares en la vertiente subepitelial de la membrana basal. No se identificaron imágenes de doble contorno. A nivel intersticial, había una fibrosis intersticial que afectaba aproximadamente el 30% del parénquima, que englobaba a las zonas de glomérulos esclerosados con un leve infiltrado inflamatorio crónico. Con las técnicas de inmunofluorescencia directa se observó positividad en patrón pseudolineal y ya a más aumento granular grueso para IgG, para C3 en menor intensidad y sin restricción para cadenas ligeras, para las cadenas ligeras, con también positividad a nivel de la membrana basal del capilar, de las membranas basales tubulares. Se hicieron técnicas de inmunohistoquímica, llama la atención que para ser una membranosa sea C4D negativa, repetida, y se hizo la tinción de IgG4 que resultó positiva. También se utilizaron, como se hace de manera habitual en las membranosas, la tinción para PLA2R y trombosponina D7A que fueron negativas. También se hizo microscopía electrónica, como veis estas son las asas capilares. Ya llama la atención que hay zonas que para una membranosa llama la atención, zonas donde no se ve prácticamente alteración de la arquitectura y otras donde se ve la presencia de depósitos. También se veían depósitos mesangiales. Aquí unas asas con depósitos aislados y otros donde el depósito era más llamativo en la vertiente subepitelial, que condiciona reacción espiculada de la lámina densa y no claramente envueltos en el espesor de la membrana basal. No habían depósitos a nivel subendotelial ni en las membranas basales de la cápsula de Bowman. Aquí veis los depósitos que no eran organizados, no tenían estructura interna y llamaba la atención también a nivel del túbulo la presencia de depósitos marcadamente electrondensos de aspecto amorfo también en la membrana basal tubular. Con todo esto se llegó al diagnóstico de una glomerulonefritis membranosa estadio 2 con depósitos mesangiales, lo que sugiere un origen secundario y también en la membrana basal de las células del epitelio del túbulo proximal. Y también las lesiones encuadrables en una nefritis tubulointersticial crónica.
Pues bien, el mercurio es un metal pesado que, dependiendo de la forma química, la podemos diferenciar entre mercurio metálico, inorgánico y orgánico. En nuestro caso, la instilación de mercurio fue del tipo metálico. La vía de exposición más frecuente es la inhalatoria y la afectación de los órganos principalmente serán del sistema nervioso central, el sistema nervioso periférico y a nivel renal manifestado principalmente por una proteinuria. Existe un tratamiento que será quelante y que lo describiré de forma breve también más adelante. La toxicidad está determinada principalmente por dos mecanismos: la oxidación del mercurio a ion mercúrico, que precipita con las proteínas ocasionando una necrosis directa. Este ion se deposita en los riñones con el consecuente fracaso renal agudo por la necrosis del epitelio tubular proximal. Y por otro lado tenemos la afinidad del mercurio inorgánico por los grupos sulfidrilos, que provoca la inhibición de los complejos enzimáticos ocasionando una acidosis metabólica que puede ser refractaria al tratamiento e incluso mortal. Pero además de este mecanismo se ha descrito que se puede ocasionar una glomerulonefritis de origen autoinmune o ambos de forma coexistente. Esta es una revisión sistemática que reúne casos desde 1950 hasta 2010 que toma como criterios de inclusión tanto síndrome nefrótico, proteinuria en rango nefrótico y un resultado histológico compatible con este diagnóstico. Se incluyen un total de 42 pacientes, se realizan 26 biopsias y los hallazgos más frecuentes a nivel histológico glomerular fueron una glomerulonefritis membranosa, una enfermedad de cambios mínimos, también menos frecuente la glomerulonefritis proliferativa crónica y la glomerulonefritis focal y segmentaria. También a nivel tubulointersticial fue frecuente la nefritis y menos frecuente, pero también hubo un caso de necrosis tubular aguda. Este es un estudio de la India que describe esta entidad en relación a medicina tradicional. Los hallazgos histológicos pues, son similares a los descritos en una nefropatía membranosa y de forma particular que los depósitos los depósitos de IgG frecuentemente son de G1, de su tipo G1, que lo que vemos frecuentemente de G4 en la etiología primaria, lo cual no fue concordante en nuestro caso. Y luego a nivel ultraestructural, los depósitos subepiteliales, pero también mesangiales, y menos frecuentes subendoteliales. En el tratamiento, pues las estrategias tienen que ser multidisciplinares. Intentar la excisión del depósito en el sitio de inyección, esto en las intoxicaciones agudas, intentar una ligadura de los vasos, y el tratamiento quelante, que será la piedra angular. Tenemos el ácido dimercaptosuccínico, que es el más frecuentemente empleado, pero que produce una eliminación del mercurio a un ritmo tan lento que podrían llevar incluso años. Por esto mismo es que se ha postulado la asociación de este tratamiento quelante con la hemodiálisis o el intercambio plasmático por el tamaño de lo que sería el mercurio asociado al quelante. Pero vemos que los resultados pueden ser un poco contradictorios, porque no siempre ha resultado en un beneficio. En cuanto a nuestro paciente, se llegó a estabilizar la función del riñón, la proteinuria, y habíamos llegado a este punto hasta la presentación del caso en la Glosen. Ya con la disposición del quelante, empezamos la diálisis extendida, midiendo las concentraciones de mercurio plasmáticas urinarias y en el líquido de diálisis con una ineficacia en la disminución de los mismos. Se intentó una HFR con mejores resultados, y luego en la evolución pues tuvo la retirada del catéter teniendo en cuenta el perfil psiquiátrico del paciente, y tras un deterioro de la función del riñón se decide una nueva realización de biopsia renal.
En resumen, la biopsia renal tenía los mismos hallazgos, una fibrosis intersticial aproximadamente el 30%, con persistencia de las lesiones de nefropatía membranosa. En este caso, lo que se agregaba eran signos de necrosis tubular aguda con pérdida del ribete del cepillo, aplanamiento y descamación del epitelio hacia la luz tubular. La inmunofluorescencia directa fue exactamente concordante con la biopsia previa, y los depósitos también en un patrón de membranosa estadio 2. Así que al diagnóstico previo se agregó el diagnóstico de necrosis tubular aguda.
Como conclusiones, el diagnóstico y el tratamiento oportuno son claves. La exposición al mercurio puede producir distintas glomerulopatías, y ante un síndrome nefrótico de causa no establecida hay que indagar sobre posibles fuentes, que serán principalmente en el ámbito ocupacional. El tratamiento combinado, la dificultad para la eliminación del mercurio en un corto periodo de tiempo con cualquier tipo de tratamiento, pero bueno, ante la falta de evidencia absoluta, lo que se plantea es un uso combinado tanto de tratamiento quelante y diálisis, y hay que tener en cuenta las complicaciones que se pueden quedar derivadas del mercurio residual, con un seguimiento a largo plazo. Gracias.
Muchas gracias, vamos mal de tiempo, así que pasamos a la siguiente ponencia y luego las preguntas todas juntas. El siguiente caso, me ponéis el título, leucemia linfática y síndrome nefrótico masivo, y lo presenta Javier Carrillo y Remedios Toledo. Adelante.
Bueno, pues comenzamos, que no tenemos mucho tiempo. Gracias por estar aquí, que sabemos que la hora es muy mala. Bueno, nuestro caso es de un paciente con leucemia linfática crónica que desarrolla un síndrome nefrótico masivo. Es bien conocido que las discrasias de células plasmáticas se relacionan con enfermedad renal. Sin embargo, la afectación renal en el contexto de los trastornos linfoproliferativos es muy poco conocida, y la única información disponible procede de pequeñas series de casos. La leucemia linfocítica crónica no es más que una neoplasia linfoproliferativa caracterizada por la proliferación de un clon de células B en sangre, médula ósea, ganglio linfático y bazo. Va a tener un curso muy variable, y destacar que hay hasta un 50% de pacientes que permanecen asintomáticos o paucisintomáticos sin necesidad de iniciar ningún tratamiento específico. Destacar que la afectación extramedular y extranodal es muy rara, siendo la afectación renal muy infrecuente. Bueno, pues este es nuestro paciente, un varón de 37 años sin antecedentes patológicos de interés, que 3 años antes de llegar a nuestra consulta pues fue diagnosticado de una leucemia linfocítica crónica, cursaba con leucocitosis, esplenomegalia y venía siguiendo revisión en consulta de hematología. Y bueno, había sido catalogado como un paciente de bajo riesgo, no estaba sintomático y por eso pues no se le había indicado ningún tratamiento. 3 años después de establecerse este diagnóstico, aparece con una marcada edematización en el contexto de un síndrome nefrótico. En ese momento pues mantenía una función renal conservada, una proteinuria masiva de 12 gramos en 24 horas, hipoalbuminemia, microhematuria y los riñones eran de tamaño y morfología normal. En el resto de estudios analíticos destaca la hipocomplementemia a expensas de C3 con C4 normal y el resto del estudio era negativo, incluida crioglobulina. No se detectó ningún componente monoclonal, ni en sangre ni en orina. Sí es verdad que las cadenas ligeras libres de capa estaban discretamente aumentadas y el cociente capa-lambda pues también ligeramente aumentado. De manera que en este punto pues se le indica la biopsia renal y bueno, ahí teníamos algunas de las sospechas clínicas que barajábamos en ese momento.
Bueno, pues nosotros recibimos una muestra representativa con un adecuado número de estructuras glomerulares en las que tanto los vasos como los túbulos y el intersticio no presentan alteraciones significativas, pero sí que nos llamó la atención el tamaño de los glomérulos. Estos glomérulos presentan un patrón nodular con unos depósitos eosinófilos y además asocian proliferación celular. A bajo aumento vemos que la proliferación celular es endocapilar y en algún punto llega a obstruir las luces de los capilares. Respecto a los depósitos, se localizan a nivel mesangial, engrosando las paredes de los capilares y también los encontramos a nivel subendotelial. Aquí tenemos un mayor detalle de estos hallazgos histológicos, tanto de la proliferación celular como de los depósitos, y en definitiva lo que tenemos es un patrón membrano proliferativo. También encontramos de forma aislada proliferación de células epiteliales formando pequeñas semilunas. En la inmunofluorescencia tuvimos un resultado positivo a nivel mesangial y subendotelial para IgG y C3, una positividad para cadenas ligeras capas y negatividad para lambda. Con esta histología y este resultado de inmunofluorescencia nos planteamos una glomerulopatía fibrilar, para lo que solicitamos el anti-DNA JB9 que resultó negativo, por lo que esta entidad queda descartada. Y en este punto, y en espera de los resultados de la microscopía electrónica, nuestro diagnóstico fue de glomerulonefritis de patrón membrano proliferativo monoclonal kappa. Algunas entidades que barajamos en nuestro diagnóstico diferencial fue una amiloidosis, para lo que solicitamos un rojo Congo que resultó negativo, una glomerulopatía crioglobulinémica, pero las crioglobulinas de este paciente habían sido reiteradamente negativas, una glomerulopatía inmunotaxoide y una glomerulopatía proliferativa con depósitos de IgG monoclonal. Y para llegar al diagnóstico final, pues necesitábamos la microscopía electrónica. En esta imagen de microscopía electrónica, ya a bajo aumento, vemos una serie de depósitos que cuando bajamos vemos que son unas estructuras fibrilares, no demasiado electrodensas y que se localizan a nivel subepitelial, a nivel subendotelial y también las encontramos a nivel mesangial. Estos depósitos presentan una llamativa estructura organizada, formando unos haces en paralelo. Y cuando los pillamos en un corte transversal, pues vemos que realmente son microtúbulos con un centro electrón lúcido, por lo que finalmente nuestro diagnóstico fue de glomerulopatía inmunotaxoide. Me gustaría recalcar que el tamaño de los microtúbulos que encontramos en nuestro paciente fue de unos 15 nanómetros, algo menor de lo que normalmente se describe para esta entidad. Sin embargo, está recogido en la literatura que los pacientes con glomerulopatía inmunotaxoide y con un síndrome linfoproliferativo subyacente, como en nuestro caso que tenía una leucemia linfática crónica, presentan un menor tamaño de los microtúbulos.
Bueno, ¿y cómo evoluciona el paciente? Pues cuando tenemos la información de la biopsia en la que ya se encuentran estos depósitos inmunes que son monoclonales, lo que traduce que la enfermedad renal está causada por una inmunoglobulina monoclonal, contactamos con hematología y sí es verdad que inicialmente nos costó un poco de trabajo convencer al hematólogo de que la enfermedad renal estaba causada por una proteína monoclonal, aunque no se detectara ese componente monoclonal ni en sangre ni en orina, sí que estaba presente en la biopsia. Bueno, pues finalmente se decide tratar al paciente con rituximab, un fármaco dirigido frente al clon de células B que tenía este paciente, recibe 4 dosis, vemos como hay un descenso marcado y sostenido de la proteinuria, En la última revisión, ya al año del diagnóstico, la proteinuria es de 800 miligramos en 24 horas. La función renal se ha mantenido conservada en todo momento, se normalizaron los niveles de albúmina y en cuanto a los parámetros hematológicos, pues ha descendido la esplenomegalia, se han normalizado los leucocitos en sangre periférica, también el nivel de cadena ligera kappa se ha normalizado, igual que el cociente kappa-lambda. De manera que el paciente se encuentra en remisión hematológica y en remisión renal en este momento. ¿Qué nos dice la literatura? Bueno, pues que la glomerulopatía inmunotactoide es una entidad muy infrecuente, definida por esos depósitos que hemos visto tan característicos a nivel ultraestructural, se asocia a enfermedades hematológicas, principalmente trastornos linfoproliferativos como el que presentaba nuestro paciente o a gammapatías monoclonales. Los depósitos inmunes que encontramos pueden ser monoclonales, mayormente asociados a esas enfermedades hematológicas, o policlonales. La patogénesis, la base bioquímica que lleva a la formación de estas estructuras microtubulares, pues no es bien conocida. Parece ser que se relaciona con determinadas propiedades estructurales y físico-químicas de la proteína monoclonal que le confieren esa capacidad para polimerizar formando microtúbulos. Estos pacientes se suelen presentar con proteinuria de alto rango, microhematuria, insuficiencia renal e hipertensión arterial. Algunos presentan hipocomplementemia. Destacar que se detecta proteína monoclonal en el 60-70% de estos casos con inmunotactoide monoclonal, por ende hay hasta un 40% de pacientes en los que no se detecta este componente monoclonal ni en sangre ni en orina, como ocurría con nuestro paciente, lo que traduce que la cantidad de esa proteína monoclonal es pequeña. Nada que añadir de la anatomía patológica que ya ha sido comentada. Y en relación al tratamiento, bueno, pues hay muy pocas series descritas y son muy pocos los trabajos que han podido evaluar la evolución de estos pacientes. Tenemos esta serie francesa de 27 pacientes, se estudian estos pacientes de forma retrospectiva, son todos pacientes con una inmunotactoide monoclonal, la mitad de ellos con un trastorno linfoproliferativo y la otra mitad con una gammapatía monoclonal de significado renal. Reciben distintos esquemas de tratamiento, pero podemos ver cómo todos aquellos pacientes que reciben quimioterapia dirigida al clon alcanzan una respuesta hematológica y renal, respuesta que puede ser completa o parcial, pero respuesta al fin y al cabo. Es verdad que la mitad de estos pacientes que responden inicialmente luego van a sufrir una recaída. Cuando sufren la recaída, pues reciben una segunda línea de tratamiento, de nuevo con quimioterapia, y la mayoría de ellos suelen responder nuevamente a este segundo ciclo de tratamiento. En esta serie hubo 7 pacientes que alcanzan enfermedad renal crónica terminal y vemos cómo la supervivencia renal es mejor en estos pacientes que reciben terapia clon dirigida, y también es mejor en los pacientes con un trastorno linfoproliferativo frente a los que padecen una gammapatía monoclonal de significado renal. La gammapatía monoclonal de significado renal es una terminología que engloba a una amplia gama de nefropatías que tienen todas como característica común el que están causadas por una inmunoglobulina monoclonal. Esto ocurre en el contexto de una proliferación clonal o bien de células B o bien de células plasmáticas. Suelen ser un clon muy pequeño que produce pequeña cantidad de inmunoglobulina monoclonal, pero que es tóxica. Es capaz de inducir todo este tipo de patología, de manera que es necesario iniciar un tratamiento para controlar el clon y disminuir la producción de esa inmunoglobulina monoclonal pequeña pero tóxica. La indicación de tratamiento pues viene dada por la afectación renal. En ausencia de afectación renal no hay que tratar estas gammapatías y nada más, venga. Para concluir, destacar la importancia de la biopsia renal es fundamental. Sin biopsia renal no tenemos diagnóstico y sin diagnóstico no hay tratamiento. Es fundamental contar con el hematólogo en estos casos que nos van a ayudar a dirigir el tratamiento y a seguir conjuntamente a estos pacientes. El manejo, muy importante, pasa por tratar precozmente a estos pacientes. Hay que controlar el clon y disminuir esa inmunoglobulina monoclonal pequeña pero tóxica. Preferentemente empleando estrategias clon dirigidas y todo ello para preservar la función renal y evitar así la progresión tanto renal como sistémica. Y esto es lo que os queríamos contar.
Muchas gracias. No sé, yo creo que vamos a dar un turno que sea una pregunta si alguien quiere intervenir. Pues si no es así, muchas gracias por acudir a estas malas horas.